we know that the standard of care for treating brain metastases has changed over the past few decades. Initially, it was just treated with whole brain radiotherapy. Then the addition of surgery was found to have a survival benefit along with whole brain radiotherapy. Stereotactic radiotherapy for a single metastasis causes similar survival outcomes as performing surgery. And then further trials omitted the adjuvant whole brain radiotherapy, so single stereotactic radiosurgery alone for a single brain metastasis became standard of care. Then the standard of care for multiple brain metastases has been changing, and the definition of multiple brain metastases has changed over time. So the initial trials looked at treating between 1 to 4 brain metastases with stereotactic radiotherapy alone, and there is now prospective randomized data to show that survival outcomes are positive for patients treated with stereotactic radiotherapy alone. So that's become standard of care. There's been further data looking at treating between 5 to 10 brain metastases with stereotactic radiotherapy alone. There's no prospective randomized data, but there is prospective observational data for that patient group. And that has now been incorporated to most international guidelines so that this treatment of up to 10 brain metastases with stereotactic radiotherapy alone is not particularly controversial. The issues arise in treating patients with more than 10 brain metastases with stereotactic radiotherapy alone. There's not much data published on the outcomes of these patients. It's thought to be a poor prognostic marker. And then the more metastases you treat, the increased risk you get of getting side effects. So the ideal scenario would be that you would have a prospective randomized trial of patients with more than 10 metastases compared with those with less to see if there's any difference in survival outcomes based on just the number. But those trials have failed to accrue sufficient patient numbers to be able to present any results. And that may be because there's not equipoise and people believe that a number of brain metastases correlates to worse outcomes, so they're not referred for those trials. So there's currently still a dependence on real-world data to show what the survival outcomes for this patient group is. And this is where our analysis has come in. So we performed a multi-center cohort study of patients referred to three tertiary centers for their brain metastases. We performed a retrospective analysis of patients with 10 or more brain metastases and their survival outcomes, and we volume matched their survival against the group with 5 to 9 metastases and another group with 1 to 4 metastases. We also performed a multivariate analysis to see what factors specifically in that 10 plus patient group would predict for a poor outcome. And that was the number of metastases or the volume of the disease or what their primary malignancy was. We also looked at the use of intracranially active systemic agents, which are becoming more prevalent, and also what their extracranial disease was doing. And our analysis found that there was not a statistically significant difference in survival in patients who were treated with stereotactic radiotherapy alone with 10 or more metastases compared to either the 5 to 9 metastases group or the 1 to 4 metastases group. And our multivariate analysis showed that increasing numbers of metastases did not have a statistically significant it was not a statistically significant predictor for poor survival, whereas increasing volume was, and also having a non-small cell primary cancer was as well. And that's been correlated in other studies looking at the treatment of brain metastases. And interestingly, we found that the use of systemic agents with intracranial penetrance had a statistically significant benefit in terms of overall survival for that patient. So we think this is added to the evidence base for treating selected groups of patients with 10 or more brain metastases. And at the very least, we would hope that this would encourage enrollment into future randomized control studies for that patient group. And there are some ongoing. We just hope that they will accrue more numbers.